Вы можете начинать, они смогут трансляцию перематывать назад.
То есть я уже сажусь?
Да.
Жду, когда вы подключитесь, или уже...
Уже все работает.
Все работает,
да.
я могу начинать и
Да,
говорить.
они начнут регистрироваться, вы увидите, но записи перемотают и перепросмотрят, что не успели.
Это их проблема. Я просто от начала до конца сейчас говорю. И знаю, что вы там где-то есть, смотрите, если что-то у меня... Спасибо большое. Так, подождите еще секундочку. Как передвигаю слайды я?
Вот следующий слайд. Но вот это окошко должно быть поверх, именно вот это окошко.
Это предыдущий.
Да.
Нет, я не туда пошла. Все, спасибо большое. Good morning, my dear colleagues. I'm Associate Professor of the Department of Obstetrics and Gynecology and Perinatology #1, Docent Kamilova Irina Kakharovna. And I will deliver lecture. It will be the first lecture for this course today. And we will start from discussion of intrapartum and postpartum hemorrhages, including hypotonic bleeding, disseminated intravascular coagulation, embolistic fluid, amniotic fluid embolism, paying attention to the management of these severe situations. First of all, as an introduction, few words about the importance, social, medical and economical importance of the group of the diseases which are leading to hemorrhages during the labor process, postpartum period and generally during gestational period. According to WHO, any vaginal or uterine bleeding in pregnancy, labor, in postpartum period defined as obstetrical hemorrhage undependent on a real reason which is leading to development of this hemorrhage. What does it mean, real reason? These obstetrical hemorrhages usually divided into two large groups, related to pregnancy, unrelated to pregnancy. Thus, the topic for today, bleedings, just related to pregnancy. In this bleeding will take place, may happen during the labor process and postpartum period. As about bleedings which are not related to pregnancy, these are bleedings which may appear in a pregnant woman presenting hemorrhage from the vagina, uterus, which are dependent on the presence of some oncological diseases. For example, malignant tumors of the uterus, which are dependent on varicoses, which are dependent on some other extragenital diseases. Pregnancy is not the reason of appearance of this hemorrhage, but if this bleeding is appeared during the pregnancy, during gestational period, all over the world, it had to be defined as obstetrical bleeding. What about social medical importance or urgency of obstetric hemorrhages? The rate of appearance of obstetric hemorrhages is rather high. You see that it is complicated. More than 4% of spontaneous vaginal delivery, statistically, over the world, complicated by different types of hemorrhages. More than 6% of cesarean section or operative abdominal delivery, statistically, every year, are complicated by hemorrhages. And obstetrical bleeding from year to year, from decade to decade, presenting one of the three most important reasons of maternal death in the world in whole. These three most frequent reasons of a maternal death in the world are septic complications, bleedings, and hypertensive diseases in pregnancy. They are changing the order one after another, from decade to decade, from country to country, from year to year. But within the last century, they still confirm the most frequent reasons of maternal death. That's why we had to pay specific attention to the diagnosis, management of any situation which may be compound, which may be complicated by bleeding, to be able to prevent it and to make correction treatment in resuscitation. Very short slide just now showing us what are main important reasons or pathological situations leading to appearance of bleeding in late pregnancy and in labor. As about bleedings which will take place at early terms of pregnancy, they would be presented during the next lecture. Today we will speak about bleedings in the first, second stage of labor, in the third stage of labor mostly, and postpartum bleeding. Our main attention would be referred today to appearance of specific situation leading to maternal death having fatal subsequences, as well as disseminated intravascular coagulation, hemorrhagic shock, and so on and so on. But few words about reasons which are leading to the bleeding appearance in labor and in late pregnancy. So hemorrhages which you may meet, and you will exactly meet it in your practice, in late pregnancy and the first and second stage of labor are as follows: placenta previa, placental abruption, ruptured vasa previa, uterine rupture, disseminated intravascular coagulation. The reasons which are leading to DIC syndrome during the pregnancy and in labor are different. Hypertensive disorders, dead fetus, septic complications, previous extragenital diseases. It is a complication, it is a subsequent of some specific situation which you already had it before pregnancy or during the pregnancy. But it may take place, DIC may take place in late pregnancy and in labor process, as well as in postpartum period. We can understand hemorrhage shock will lead to DIC development. Hemorrhages in the third stage of labor and postpartum are specific hemorrhages, and they appear because of specific reasons. Main groups of these reasons are presented here: retained products of conception, retained tissue of the placenta, trauma, genital tract lacerations, uterine rupture, coagulation disorder, as we already told, uterine invasion, incorrect management of the third stage of labor, uterine atony, which is dependent on the course of the previous stages of labor and dependent on the management of labor. Here is presented ICD classification. A part of ICD classification related to hemorrhagic complications in pregnancy, labor, and postpartum periods. Because of the amount of information we had to discuss today, we will not pay attention to any point from this classification. We decided to refer you to ICD-10 classification because any modern practitioner graduated from the university had to know how to work with this ICD-10 classification. And generally, all the reasons which are leading to hemorrhage, which were presented in previous slide, are already presented here, but with special quotes. That's why let ICD-10 classification be in your notebook, be on your table every day while you're learning, studying, not only obstetrics but medicine in whole. So it is presented placenta previa, premature separation of normally implanted placenta, antepartum hemorrhages or antepartum bleeding, which means bleeding which appeared before the beginning of labor in pregnancy. Bleeding which appeared during labor, known as intrapartum bleeding, and postpartum bleeding which appear after the labor process. And if you see this slide just now, you already understand it is the same list of diseases which was presented during the first slide. So here postpartum bleeding, we had to pay attention to the general etiological factors. What are reasons leading to development of bleeding during gestational process, and mostly in the third stage of labor and postpartum? First of all, it is complicated obstetrical anamnesis, hypertensive disorders in pregnancy. What about complicated obstetrical anamnesis? Your patient already had bleeding during different episodes of your previous history, obstetrical bleeding, uterine bleeding, and unrelated to pregnancy. Thus, if she already had it or has it, you can understand that she may have the same situation during the current pregnancy and labor. Big fetus usually means that the uterus has excessive contractions, makes excessive contractions during the labor process. During the pregnancy, this uterus is overextended, and it is both these factors. They are leading usually to the lack of uterine contractility, not only in the labor process but in postpartum period, and postpartum period complicated with lack of uterine contractions. Uterine hypotony or atony is very, very risky for appearance of excessive, massive bleeding up to the maternal death. Myoma of the uterus. It is failure of the structure of myometrial tissue, layers of myometrium, and it is followed with dysfunction of contractility of the uterus. A uterine scar, because of the same mechanical reasons and histological changes, will present very high risk for bleeding in pregnancy and in labor. The chronic form of disseminated intravascular coagulation, by the way, for populations which are South populations which are suffering from anemia, different form of anemia. It is very typical for these populations to have so non-chronic form or subclinical form of disseminated intravascular coagulation. Nowadays there is opinion that there is no chronic form. Maybe let it be no chronic form, but the risk for development of acute DIC syndrome is higher in these categories of patients. For example, those who are suffering from anemia because of failure of lipid, protein and other types of metabolism, membrane or RBCs become very hard, not so elastic, and while trying to pass through microvessels, they may be ruptured. It is followed with hemolytic component appearance, and it is followed with appearance of situation leading for DIC syndrome. Thrombocytopathies, antenatal fetal death. They are other risk factors, and it seems to me that it is rather understandable. Before we will start to discuss main point of our lecture for today, mostly we will tell about, I repeat it again, about bleeding in third stage of labor, in postpartum bleeding, including severe situation in which your patient will need resuscitation, intensive therapy in obstetrics. Those other types of bleeding will be discussed later. As about these types of hemorrhages, most important for us, first of all, to understand, to memorize what are the main mechanisms of appearance of bleeding or arresting of bleeding in the third stage of labor. Excuse me, please. Appearance of bleeding will appear in labor process as well as at any outcome of pregnancy because of detachment of the chorionic plate or detachment of the placenta from the uterine wall, which means rupture of membranes connecting fetus placenta, amniotic sac, embryo with the uterine wall, and rupture of these membranes followed with bleeding. Thus, we understood any outcome of pregnancy will follow with bleeding. Outcome, expulsion of conceptors means bleeding. It is natural process. But now there is one of the most important points. We had to understand how to prevent excessive, massive, pathological bleeding, how to arrest it. To understand how to prevent, we had to imagine mechanism of arresting. So, the mechanism of arresting of bleeding in the third stage of labor mostly dependent on the uterine contractions. Here is presented mechanism of uterine muscles contractions. Here is presented special picture which is used from textbook to textbook. You will see it in any sites, in any textbook. It is known as living ligature. Pay attention please, let me memorize. There are three layers of uterine muscles. Outer layer of uterine, not uterine layers, but uterine muscles layers. Outer layer of uterine muscle is longitudinal, longitudinally directed muscular fibers. The mid layer is oblique muscles, the most significantly presented. And the anal layer of uterine muscles presented with saccular muscular fibers. And what do we have? We have number of muscular fibers which are located in relation to each other as a net. And between these net, we have the ends of spiral arteries, microvessels, the ending parts of spiral arteries. While the muscles are relaxed, spiral arteries are filled with blood. But when muscles would contract, will make contraction, retraction, it means that any muscle will become thicker and shorter. It is followed with closure of the net cells, and it is followed with compression of the final end of spiral arteries, followed with the resting closure of these arteries just after the rupture and arresting of bleeding. Here is another schematic picture showing how compression of these muscles, which is happening due to the contractions of muscles, will lead to closure of the vessel's patency and arresting of bleeding. Here is another picture, maybe more comfortable to you to understand. It is presented here, so now net, understood, cellular, and inside this cellular we see the ends of spiral muscles, spiral arteries. Here are different layers of musculature. It is shown what's happened when they will contract, and it is shown here they will become thicker, and it is followed with compression and closure of the ends of ruptured vessels, microvessels. This is the main mechanism of hemostasis, natural mechanism of hemostasis. Mostly any bleeding from uterus in pregnancy, not in pregnancy, at any situation, is characterized with the same mechanism. Living like HR, myotamponade, different terms are used. We had to learn it by heart, we had to understand. Thus, when I want to arrest any bleeding from the uterus, the most important for me to make contractions of uterine muscles, to improve contractions, to induce contractions, or even make mechanically just for this moment to arrest this bleeding. So, if we understand, we can discuss the second mechanism of hemostasis, secondary. It is of the same importance, but it is secondary. Thus, increased blood coagulability. And actually, blood coagulability starts to be increased from the very beginning of pregnancy. Gradually it is increasing, getting its tip maximum of intensity just closely to the liver, and in liver takes its important, makes it important role in the mechanism of arresting of bleeding. Thus, we will have bleeding during any labor. We mean our patient and we practitioner who are managing this labor. Our main idea, as fast as possible, within few seconds, to arrest this bleeding. If we know that the most important component of arresting of bleeding is contraction, we are making something to improve this contraction, to increase the intensity of the contraction. Entering oxytocin, we will tell about it. Or we'll try to make massage of the uterus. Not at any situation is useful, but still useful. And in relation to this situation, we had to memorize that bleeding, obstetrical bleeding, definition of bleeding in postpartum period, defined to situation when patient has more than 400 to 1500 ml of blood loss throughout all process of labor, including all stages of labor and early postpartum period. There is one rule we had to pay attention to this point. The volume of physiological blood loss, as it is presented in this slide, volume of physiological blood loss should not be more than 0.5% of the body weight of the patient. Thus, for example, if your patient's body weight is 60 kg, 0.5% of the body weight would mean for this patient 300 ml. If your patient, for example, of 220 kg, it does mean that she may have 60 or more 600 or more milliliters of blood loss. Independent of blood loss, the volume of physiological blood should not exceed 500 ml. And there is one other component I wanted to tell about it. It is not presented in this slide, but it is of great importance. Almost the ones who are sitting in this auditorium are from South countries. Most of our students are from India. India, as well as any other South countries, they are characterized not with the special social economical condition and so on, but because of specificity, mostly due to climate, for example, hot climate. So for such categories of population by WHO who are suffering from anemia, who are living in hot climate and so on, there is other room of evaluation of physiological blood loss for population which is presented with high risk of anemia, high incidence. The volume of physiological blood loss is 0.25% of body weight. Thus, it is lower. It means what? It doesn't mean that patient is dying, but it means that if she has, for example, 250 ml of blood loss, it is already factor which is pushing us to start measures aimed to prevention of continuation of bleeding. We are starting to use oxytocic agents, for example, uterotonic agents, increasing of uterine contractions from the earlier stage of postpartum period. Now, another important point I want to understand it. PPH causes postpartum bleeding or hemorrhage reasons. According to modern rules, you had to know what does mean 4 T's: tone, tissue, trauma, and thrombin. Tone. We already told muscular contractions are responsible mostly for arresting of bleeding. Thus, tone means if we have problems with uterine tonicity in labor, if we will have problems with uterine tonicity in postpartum period. Lack of uterine tonicity means lack of uterine contractions. Thus, the most important component of arresting of bleeding is already failure. So, what are risk factors for uterine hypotonicity, atonicity, uterine tone failure? These factors are some maternal science profile, aged patient, patient whose obesity, body mass index is 35 and more. It is shown in statistics that Asian ethnicity is more risky for appearance of this situation. That's why for this population there are some other rules of evaluation of physiological blood loss. Uterine overdistension because of big fetus, because of multiple pregnancy, increased volume of amniotic fluid, and so on. Overdistension will lead to lack of uterine tonicity. Prolonged labor process, induction of labor, which was repeated again and again, lead to lack of resources for contractions. That's why this factor is one of the risk factor of appearance of lack of uterine tonicity. Placental problem, placenta previa, placenta abruption. Placenta previa, which is located in the lower uterine segment just closely to the internal os of the uterus, characterized with overthinning of this segment, and overthinning of the segment is risky for atony, and not only overthinning of the lower uterine segment, but placental ferments, placenta its own release some ferments which improve implantation, improve fusion of the placenta with the uterine wall, which we need in pregnancy, but on the other hand, as a side effect, has lack of uterine tonicity. The next T is tissue. Tissue referred to the retention of placental tissue, placental amniotic membranes, parts of the placenta. Uterus had to be emptied to be contracted successfully. No emptying of the uterus, no successful contractions, no or lack of natural mechanism of arresting of bleeding. Trauma. rupture of uterine wall, cervical tears, some other tears, but mostly it is referred to the rupture of the cervical and uterine tissue. What are risk factors? Instrumental vaginal delivery through vagina for subsequent years delivery, episiotomy, cesarean section itself lead to increasing of the volume of bleeding. Normal volume of blood loss, physiological volume of blood loss is 0.5% of body weight, not more than 4 to 500 ml, but cesarean section successful, uncomplicated, characterized with the volume of blood loss which is closely to 800 ml up to 1000 ml. It is taking place during all the cesarean section, during in whole. In thrombin, the fourth T refers to coagulopathies and vascular abnormalities which increase the risk of primary postpartum hemorrhage. Vascular thrombopathia, coagulopathy, vasculopathia, they may be dependent on pregnancy. Exactly, they may be dependent on pregnancy as extragenital disease. This is proving us, all these factors, the importance of interrogation of the patient, as well as you can get anamnestic data, correct getting complete anamnestic information helps us to confirm correct diagnosis, and not only correct diagnosis. When we are making diagnosis, it is already happened. To confirm risk for development, prognosis, and if I know what is the risk, if I know what is the prognosis, I am able to make prevention. Uterine hypotonic condition. First T, lack of uterine contractions. You will see the terms hypotonicity, hypotonic, atonic bleeding. Usually they refers to the same situation, lack of uterine contractions. Degrees may be different, that's why sometimes we use term hypotonic, atonic. It is not so important. No, or lack of uterine contractions. Etiology, hypoplasia of the uterus, birth in elderly premipara, giving birth to a woman with a history of a large number of abortions, destruction of myometrium, nervous system of the uterus, polyhydramnios, multiple pregnancy, overdistension of the uterus during the pregnancy, the presence of myometrial knot, intoxication with feverish childbirth, overfilling of the bladder. If bladder is filled foot or rectum is filled foot, uterus may try to perform contractions, but the area where it may be located after contractions is already occupied with filled foot bladder. That's why I'm dependent on making contractions, uterus still overextended. Incorrect management of labor, kneading and massage of the abdominal wall and uterus, abnormalities of the placenta, adherent placenta, fused placenta, and so on and so on. Now, one of the most important points we had to discuss today, hypotonic bleeding. Hypotonic bleeding which may appear in the third stage of labor, placental stage of labor, as well as in early postpartum period. Early postpartum period from 2 hours within 24 hours after delivery of the baby, after childbirth. And as it is known from the term, name of this bleeding, hypertonic, or you will see in your textbook atonic, the same. Lack of uterine tonicity. Here are presented two variants. And as for me, the second variant is more, not severe, but dangerous. Because if the patient just from the very beginning has massive bleeding continuing, we already understand, everybody can understand that it is danger, that it is fatal, and we are trying to arrest it or make some special measures just from the very beginning. Absolutely other situation in the second variant of bleeding. A significant blood loss, make massage, disappeared. After 15-10 minutes, appear again, 30 to 50 ml, massage, disappeared. Then again and again, appearance of bleeding with small or not so small portions. We are making massage, we are entering ultrasonics again and again. We are coming to this patient 50 ml, 70 ml, no reasons to make laparotomy. But at last, after 2 hours, we already understood she's lying in this stage of hemorrhage, shock first or even some second, because not massive, small portion, larger portion, small portion, individual different portions of blood loss, and some presenting more than 1,000 milliliter, more than liter, and she already has lack of resources to arrest this bleeding. Thus, for practitioner, the second variant is more dangerous because it will not push us to make resuscitation just from the very beginning. So, here are presented clinical features of bleeding. Maybe we will not last time for the bleeding appearance. Symptoms is blood loss, appearance of blood from vagina, dependent on the volume of blood loss, signs of shock will appear. So, as about the management, I am trying to pay your attention. If you see hypotonic bleeding, don't lose time for repetition again and again of different conservative methods of arresting of bleeding. Don't forget about second variant of bleeding. Thus, the management of atonic hemorrhage should include the simulation, delivery of train, for example. Teamwork. When the bleeding is severe, walking everyone who is presented in the hospital. Resuscitation, immediate management. You had to start resuscitation in one or another form just from the very beginning. Investigations and monitoring measures to arrest bleeding. TRIM, known by WHO. The basic goals are maximum rapid arrest of bleeding, prevention of development of massive blood loss, renewal of the circulating blood volume deficiency, stabilization of hemodynamics. Measures should be executed quickly, simultaneously, that determines the efficacy. We are writing in our textbooks protocol 1, 2nd, 3rd. It doesn't mean that you will make these measures one after another. And usually teamwork means what? Everybody, starting from those who are washing the floor up to the manager, supervisor of supervisors of practitioners knows what to do. One is working with the patient, another preparing blood for transfusion, the other working with resuscitation, and so on and so on. Here is presented the list of drugs used in hypotonic bleeding by the protocol of WHO, and you will use these drugs excessively. These are presented. Here are presented drug names which are used in your country, mostly in India, because the most of our students are Indian students. So, fixed dose combination of oxytocin and ergometrin, syntocinon. We use oxytocin. We use ergometrin separately. You will have drug which is known syntocinon, containing, it is pharmaceutic medicine, containing different doses of syntocinon, combination of oxytocin and ergometrin. Carbetocin, ultrasonic drug. Injectable prostaglandin, different brand names. Misoprostol tablet used via oral, sublingual and rectal routes. Why not? We are making it. We are using it. Interrectal. Injectable tranexamic acid. Injectable recombinant factor 7A in the management of hypotonic bleeding. They are proposed by WHO. So, just here presenting 3 steps of the immediate management of hypotonic bleeding in labor theater. Bleeding is severe, independent on the brand. First step, bladder had to be evacuated. If not evacuated, make it just now. Uterus massage through abdominal wall had to be done as it is written here. I hope you will save, download this lecture and read again how you will make massage. Manual removal of blood clots, independent on the possible reason. You had to ensure that uterus is empty. If uterus is not empty, uterus will have no good contractility, no good contractions, successful adequate contractions, strong contractions we need, no arresting of bleeding. Coming back again to the main mechanism of arresting of bleeding. Even if there are no remnants, you're absolutely sure. Maybe uterus containing just now some volume of fluids because of lack of tonicity, fluids are arrested and they are itself secondary prevent uterine contractions. Maybe she has rupture of the uterus, who knows? Maybe she has microscopic arrests of microscopic fragments of placental tissue. At any of these cases, at the first step, exactly, manual removal of the uterus to increase contractions had to be done. What does it mean? Well, you're making evacuation of bladder, somebody makes evacuation of bladder, you're preparing yourself for abdominal operation, washing your hands and so on and so on. A reanimatologist already start to give narcosis because exactly you will make a manual controlled revision of the uterine cavity to remove blood clots, to remove possible remnants, and ensure that there is no trauma. Don't forget about 4 T's. Revision of the soft tissue of the labor canal must be done to repair lacerations because maybe she has bleeding due to laceration. If there are lacerations, stitching, of course. And infusion of frozen plasma, albumin, protein, blood, intensive infusional, transfusional therapy had to be started. If I don't know what would be the further cause of hypotonic bleeding, I had to mobilize vein just from the very beginning. Again, that's why we are working as a team. While I'm making manual revision of the uterus, my colleague is starting to make intensive infusional, transfusional therapy. 1 or better 2 veins are already mobilized. Let it be crystalloid just from the very beginning while we are preparing colloid solution which are presented here to arrest the bleeding. If the uterine hypertonia arrested, these measures may be enough. But it doesn't mean that you are arrested to work with the patient. You had to stay near the patient to make control, to ensure that it is really arrested. Here is presented how massage of the uterus would be done. Bimanual compression is done to stimulate uterine contractions. Drug doses for management of hypertonic bleeding. These doses are presented according to the protocol of WHO. That's why it is of great importance for those who are going to work out of Russia. It is presented especially for you. I propose to read it, write or save, download it, and remember. You may find it in yourself. Opening WHO protocol related to hypertonic bleeding. So it is shown here, oxytocin intravenously. We start from 20 units intravenously with the rate of 60 drops per minute, and continuing dose 20 units intravenously with the rate of 40 drops per minute, and so on and so on. Here is presented oxytocin, ergomethyl, methylergometrin, and prostaglandin after alpha. So the first step we made emptying of bladder, emptying massage, emptying of uterus, manual revision, immobilization of vein, and started to induce or to enter oxytocic agents in combination with the colloid crystalloid solution, intensive infusional transfusional therapy. The second step if bleeding is persist. bleeding persists, and pay attention please, the volume of hemorrhage is 0.8 to 1% of body weight. Not, for example, 300 ml, but it is already 600 ml, 6.500 ml. So conservative treatment may be continued, but you had to ready to start to prepare operating theatre for all of cases. What are conservative? This is very thin point, dependent on intensity of bleeding, because within 2 minutes it will become more than 1000 milliliters. Thus, pay attention to the general condition of patient, to her compensatory process which she has or has now, to the rate of bleeding. Thus make decision individually would you make this second step. It means the very short period of time, or it may be not so short, when you can try to arrest it with some conservative measures. Compression of abdominal aorta, how it is effective or not, you will make decision for yourself, but it is for short period of time may be done. 10 units of oxytocin intravenously, 20 units of oxytocin may be continued with 40 drops per minute. The main rule I want to understand, it is temporary. It would be very individually. You may make it, may not. If the volume of blood loss is not exceed 0.8% of body weight, let it be. The main rule I want you noted, don't lose time for any ineffective, for any conservative methods. Because if you didn't arrest it, if bleeding is not arrested with the help of conservative methods just on the first step and still continue, most frequently it is the second we run, afraid of lose time, afraid to have increasing of the volume of blood loss, and don't use again and again not effective or ineffective conservative measures. Urgent operation is the best management. Thus, we are speaking about second step, but remember, it is temporal and it may be done individually. Don't lose time. Drugs doses according to the steps are presented here. We're repeating it again. It is almost the same table, but it is so important that we decided to repeat it again. And I would be very proud of you, thankful if you will learn it or download it, if you will remember it. Please tell us about it during your exam. Please don't forget about it and use it in your practice. So, the lack of effective manual examination of the uterus cavity, continuation of bleeding, means you had to think about surgical treatment. So, some words about modern useful methods of arresting, conservative arresting of bleeding. What I can to tell you, if bleeding continues, better to think about surgical arresting of bleeding. But if bleeding arrested temporarily, we don't know for how long it would be arrested. Maybe appeared again, maybe arrested at all. We can use balloon tamponade of the uterus. And the scheme of balloon tamponade of the uterus is presented here. And during our practical class, we will tell about different types of balloon tamponade. Only don't forget about it. Main principle, the balloon, elastic balloon, empty balloon would be emptied in the uterine cavity, and then it had to be filled with some portion of fluids as it is shown here. Fluid entering the balloon will lead to opening and extension of the balloon, and when it is overextended, it will lead to tamponade of uterine walls from inside. In combination with the uterotonic drugs, it may lead to fluid with arresting of bleeding, but in details we will discuss it in practical class. And the third step of management, or second maybe, it is surgery. Narcosis, deep narcosis, intubation usually, improvement of circulation, infusional, transfusional, and intensive infusional transfusional therapy, opening of abdominal cavity, laparotomia, and arresting of bleeding. How can we arrest bleeding? use compressive suture, ligation of the great vessels, or even hysterectomy. There is only one point. If the patient is already in the stage of hemorrhage shock, we will take patient to the operating theater. Reanimatologist will start to make resuscitation simultaneously with giving of narcosis. We are not making operation just at the very beginning. We are waiting only. We are waiting for 15 minutes. It is known as operation pause. We are making laparotomia, clamping of great vessels, then waiting when resuscitation will give us report. You may continue. While we are waiting, that's 10-15 minutes. Reanimatologist, excuse for my English please. Reanimatologist starts to make resuscitation, starts to improve circulation with replacement of blood loss. Operating pause is of great importance. If I will not make this operating pause and I will try to remove uterus at once, additionally for the volume of blood loss which she already got, for example 1 to 1.5 liter, I will take out another 1 liter from blood circulation together with the uterus, because the blood is located, collected in the uterine walls and uterine cavity, and at once it will follow the dropping down of your homeostasis because of increasing of the intensity of hemorrhage shock. That's why we are making operating pause. Here presented compression sutures, different types, number of types. Most useful may be Lynch suture, but it is presented Pereira, very widely useful, modification of Lynch, and Russian Radzinski suture. In Russia we have number of modifications, not only by Radzinski. Here is presented picture showing what does the ligation suture. They are leading to contractions, pressing, pushing, increasing uterine contractions. We are making artificial diminishing of uterine volume, preventing relaxation. Then, if it is ineffective, we can make hysterectomy. We may make hysterectomy just from the very beginning. But today we have tendency of organ-saving surgical management. That's why we are telling about it after some other methods of arresting. There is another method, sandwich method. It may be done during operation after laparotomia. It is combination of balloon tamponade with Pereira or Lynch sutures. But it is maybe useful, may not. We will tell about it during our practical class. Amniotic fluid embolism. Amniotic fluid embolism. So, first of all, what does it mean, this situation? Amniotic fluid embolism is a fatal, very severe intra-obstetric complication. In this complication, what does mean this complication? Amniotic fluid containing some foreign genetic information, by the way, containing some cells of the fetal body, skin cells, hair, other debris. Together with these contents amniotic fluid, which is a self-foreign for blood, enters maternal circulation, and it is followed with development of cardiorespiratory collapse. By the way, the mechanism, pathogenesis of amniotic fluid embolism is poorly understood, but it is unique to pregnancy. It may range from a relatively minor subclinical episode, we can even don't understand that she had it, but don't think about it. Let me be very attentive to this situation. Up to appearance of catastrophe, which will deliver within few seconds, and which can lead to the fatal outcome of labor, maternal and fetal death, The underlying mechanism for amniotic fluid embolism, as I'm already tried to tell you, is poorly understood. the situation has very grave maternal and fetal consequences. Amniotic fluid embolism can occur during labor, can occur during cesarean section, dilatation evacuation, or in the immediate postpartum period. The maternal mortality rate because of amniotic fluid embolism remains around 61%. It is still one of the most important in our situation. Just from the very beginning, it is followed with rapid death or development of excessive cardiovascular catastrophe. So, it is presented here statistical information related to the rate of amniotic fluid embolism, up to 5% in the United Kingdom, more than 13 in France, 30 in Singapore, 10 in USA, Australia. No, in our country it is from 8 to 9 at different, 7 to 9 at different years. In Russia, one of the most important reasons of the death now during the last decade, even not obstetric bleeding, it is in the second or third lane, but we have some other appearance, extragenital diseases became one of the most important reasons of maternal death. It means that we are making treatment of extragenital disease before pregnancy so successfully that these patients become able to conduct pregnancy and even to make labor. So, but hemorrhages are already not at the first place of in relation to the rate of maternal death. So the fetal mortality is rather high, very high, comprehensive even with maternal mortality, and it is up to from 20 to 40%. Would you like to imagine up to 50% of fetus and mother who have amniotic fluid embolism are dying. Every second baby dead in categories of population who had amniotic fluid embolism. We will try to understand what is pathogenesis, how it is happening, what is the mechanism of appearance. If we know mechanism of appearance of any disease, we can imagine how to prevent and how to treat. Normally, amniotic fluid doesn't enter the maternal circulation because it is contained safely within the uterus, sealed off by the amniotic sac. Amniotic fluid embolism occurs when the barrier between amniotic fluid and maternal circulation is broken because of different reasons and possibly under a pressure gradient. Fluid abnormally enters the maternal venous system via the endocervical veins, the placental site if placenta is separated, or a uterine trauma site. Why this entry into maternal circulation? In woman, it will not clearly understood because all of these processes may usually take place at any labor, placental site, ruptured membranes, even microscopic traumas of the uteri may take place, but it doesn't mean exactly that patient has amniotic fluid embolism. Different gradient of intra-abdominal and intrauterine bleeding, condition of the vascular system, and so on, they are taking role, but exactly we still are interested in knowledge about exact mechanism of development of this situation. However, fetal material is not always found in the maternal circulation in patients with amniotic fluid embolism, and material of the fetal origin is often found in women who do not develop amniotic fluid embolism. Thus, make decision yourself. We don't know exactly what is the mechanism of appearance, but we are paying attention to the rupture, trauma, to the intensity of uterine contractions and the rapidness and appearance of intensive, strong uterine contractions over distension of the uterus and increased intrauterine pressure. hypotheses concerning the pathophysiology of amniotic fluid embolism are useful nowadays. Clinical symptoms result from some degranulation with the release of histamine and TTs, and clinical symptoms result from activation of the complement pathway. Thus, dependent on these points, we will have development of different stages of development of the clinical features of amniotic fluid embolism. So what are symptoms? First, phase 1. Amniotic fluid and fetal cell enter the maternal circulation, resulting in the release of the biochemical mediators which cause pulmonary artery vasospasm followed by pulmonary hypertension. This results in elevated right ventricular pressure and right ventricular dysfunction, which will lead to hypoxemia and hypotension with associated myocardial and capillary damage. Phase 1 may last up to 30 minutes. Vasospasm, pulmonary hypertension, and right ventricular dysfunction will develop during this stage, up to 30 minutes. Phase 2. This occurs in patients who survive the initial insult. Left ventricular failure and pulmonary edema occurs. Biochemical mediators trigger DIC, leading to massive hemorrhage and uterine atony. Thus, you already imagine two main features of development of amniotic fluid and two main clinical symptom complex. Here is the scheme. I hope this scheme will help you to understand the mechanism of development of this situation. Amniotic fluid gains entry to maternal bloodstream. Mechanical block will appear. Release of endogenous mediator. Mechanical blood will lead to pulmonary vessel obstruction. Release of endogenous mediator followed with pulmonary vessel vasospasm. Vasospasm and obstruction means hypoxemia or prolonged arrest, as well as acute pulmonary hypertension, right heart failure. Hypoxemia, prolonged arrest, just at once, may lead to the death, or if survived, it is followed with left ventricular failure after 30 minutes, pulmonary edema, neurological impairment, DIC, disseminated intravascular coagulation syndrome development. Patient may die just within the first phase. If she survives, she will present number of severe fatal complications. And it is followed with the rate of maternal and fetal death up to 60% in whole patients who were survived after first stage of amniotic fluid embolism. And the survival rate is 70 to 75%, different countries. Amniotic fluid embolism contains various components that contribute to the pathophysiology of AFE in different ways. Components of amniotic fluid: solution, biochemical mediators, surfactant, adrenaline, leukotriene C4 and D4, thromboxane and A2, uterotonic component, prostaglandins, arachidonic acid, leading to increased coagulability of blood, leading to activation of the platelets and its function in blood coagulability. Thromboplastin, the same. Collagen, but thromboplastin is activating not platelets. Thromboplastin is activated plasma component of blood coagulability. Collagen and tissue factor 2, phospholipase A2. And suspensions, lanugo hair, fetal hair, Vanix caseosa, fetal screams, bile stain meconium itself may lead to development of the pathogenesis of problems which are connected with amniotic fluid embolism. Fetal gut mucin and thromboplasm. How many components which are responsible for development of one or another problems which were presented on this slide? Mostly DIC. Clinical presentation. Now, I hope you already imagine clinical presentations because we told about pulmonary hypertension, we told about ventricular dysfunctions, DIC, and so on. But let me try to discuss it better. So, amniotic fluid embolism typically occurs during labor and delivery or in the immediate postpartum period, early 2 hours, just first 2 hours after delivery, after childbirth, after cesarean section, amniocentesis, removal of the placenta. For example, we had uncomplicated labor, but after delivery of the placenta, we understood that there are, or suspected that there are remnants, defect of the placental tissue, incorrect making of manual revision of the uterus may follow with appearance of amniotic fluid embolism, or it may even appear within or because during the medical therapeutic abortion. Other causes have been associated with abdominal trauma, cervical suture removal, ruptured uterus, or intrapartum amnioinfusion. Prodromal symptoms in amniotic fluid embolism are sudden chills, shivering, sweating, anxiety, and coughing, followed by signs of respiratory distress, shock, cardiovascular collapse, and convulsions. These are symptoms which are typical for pulmonary hypertension, ventricular dysfunction. We told about it when we tried to understand pathogenesis, and they will appear just at once. Duration not longer than 30 minutes, as we already told. Signs of pulmonary hypertension, ventricular diphtheria, and so on and so on. Chills, shivering, sweating, anxiety, coughing. Respiratory difficulty evidences by cyanosis, tachypnea, bronchospasm frequently culminates in fulminant pulmonary edema. Common signs and symptoms of amniotic fluid embolism: hypertension, which should be advised urgently, hypoxia signs, disseminated intravascular coagulation, cyanosis, appearance of bleeding, or signs of organ insufficiency, altered mental status, sexual activity or sexual appearance, fever, chills, headache, nausea, vomiting, evidence of fetal distress, present in 80 to 100% of affected women. Pay attention. Hypertension, hypoxia, disseminated intravascular coagulation, altered mental status, seizure, fever, chills, headache, nausea, vomiting, evidence of fetal distress. Doesn't mean that your patient will have all of these signs, but even if she presenting urgent appearance of one or two of these signs, you had to think about amniotic fluid embolism even more. Any failure of the process of labor, any failure of the general condition of patient had to think about AFA and try to exclude it in your practice. Try to exclude it with the making of differential diagnosis. The initial signs may often be seen and electrocardiogram, tachycardia with the right ventricular strain pattern and CT to T wave changes, and pulse oximetry may show sudden drop in oxygen saturation. This is followed by profound hypertension and cardiovascular collapse associated with severe respiratory distress. This is a subset of patients in whom severe hemorrhage with DIC may be the first sign. However, a definitive diagnosis is usually made by the demonstration of amniotic fluid material in the maternal circulation and in the small arteries, arterioles, and capillaries in the pulmonary vessels, but most frequently it is done in autopsy. Diagnostics. Additional diagnostic tool for confirmation of amniotic fluid embolism suspected clinically include chest X-ray may show an enlarged right atrium and ventricle and prominent proximal pulmonary artery and pulmonary edema. Will we have time to make chest X-ray to make this diagnosis? It is so urgent, so severe, so rapidly developed. Lung scan, more modern, maybe more informative, but we have emergency. Thus we may make it, we may have no time. Central venous pressure with an initial rise due to pulmonary hypertension and eventually a profound drop due to severe hemorrhage. If we made it previously, catheterization of subclavicular vein, it will help us exactly because of appearance of severe hypertension due to severe hemorrhage. Coagulation profile. Normally in pregnancy, blood coagulation factor increases. However, with amniotic fluid embolism, evidence of disseminated intravascular coagulation ensures with failure of blood to clot, decreased platelet count, decreased fibrinogen and afibrinogen anemia, prolonged prothrombin time and partially thromboplastin time, and presence of fibrin degradation products. Thus, if you work in second or tertiary hospital, immediate making of coagulation profile will help you to make diagnosis. Thrombotic pulmonary embolism. Differential diagnosis were done with thrombotic pulmonary embolism, air embolism, eclamptic convulsions and coma, convulsions from toxic reaction to local anesthetic drugs. Acute left heart failure, cerebrovascular accident, aspiration of gastric contents, and hemorrhagic shock, which may take place. What about lab tests? Arterial blood gas to assess ventilation and the degree of hypoxemia would be done. Hematocrit will fall with associated hemorrhage very fast may be done. White cells count may be elevated as an acute phase of reactant. Prolonged prothrombin and thromboplastin times. Cardiac enzymes and serum tryptase levels may be elevated. Chest radiography, electrocardiography, as we already talked. And here is presented the list of laboratory investigations, non-specific which would be done and specific: cervical, history, serum tryptase, TN antigen, and serum corpuscularin. Management of amniotic fluid embolism. Symptomatic depends on severity. Goals and treatment: maintenance of oxygenation, supplemental oxygen, tracheal intubation, ventilation, circulatory support. Resuscitation is done. Cardiopulmonary resuscitation protocol had to be done. Delivery of fetus as fast as possible. Volume in drops and afterload reduction. Correction of the coagulopathy with fresh frozen plasma, packed RBCs, platelets. General rules. Possible additional measures: high dose corticosteroids. As about corticosteroids, if you see any catastrophe, start to enter corticosteroids, start to enter adrenaline, and cardiopulmonary bypass, nitric oxide, inhaled prostacyclin. Now we already maybe imagine what is the emergency of the amniotic fluid embolism and what are main methods of management. It means resuscitation. As fast as possible make childbirth, treat coagulopathy, and improve hemodynamic homeostasis. Disseminated intravascular coagulation syndrome. Everybody know what is DIC syndrome. It is characterized with hypercoagulability, which is followed with microthrombosis, generalized disseminated microthrombosis, which is leading to occlusion of the microcirculation and appearance of polyorganic insufficiency, mostly simultaneously with hypocoagulation, which would be presented in most central circulation. What do we have? Hypercoagulation, bleeding, which appear against the background and because of hypercoagulation, disseminated intravascular coagulation. Scheme: systemic activation of coagulation, followed with widespread deposition of fibrin in microvessels at the final parts of microcirculation, followed with consumption of platelets and coagulation factors, leading to microvascular thrombosis and hypertension because of microvascular thrombosis and demand of these factors to make microthrombosis. Thus, in more central vasculature, patient presenting bleeding from more central vasculation. So what do we have? Generalized systemic activation of coagulation, obstruction of small vessels, failure of blood supply leading to multiple organ dysfunction, with bleeding, consumption coagulopathy, and shock. At the same time, enhanced consumption of coagulation factors, platelets, and so on, depletion of clotting factors with the same result. DIC, consequences of the primary pathological process. It is complication of some pathological process. What are reasons leading or working as a trigger of cascade of this generalized systemic activation of coagulation, which is presented here? What are these reasons? In obstetrical practice: preeclampsia, eclampsia, HELP syndrome, placental abruption, hemorrhage, shock, amniotic fluid embolism, sepsis, extragenital diseases, cardiovascular disorders, severe kidney diseases, liver diseases, risks incompatibility, immunological insufficiency in pregnancy, retained dead fetus syndrome, intrauterine fetal death, lead to lytic process, and components which appear during this lytic process when the fetus is arrested in the uterus cavity, enters presenting tissue thromboplastin, entering of these thromboplastic substances in the blood vessels, maternal circulation, followed to the development of DIC, transfusion of incompatible blood, catastrophic antiphospholipid syndrome, it is rather rare, and a number of other reasons. Clinical features. 4 stages of DIC are distinguished classically. First is hypercoagulation, second stage is consumption coagulopathy, dramatically reduced number of platelets due to the aggregation, decreased fibrinogen, prothrombin, and other coagulation factor levels because of excessive expenditure, because of excessive consumption, because of excessive development of microthrombosis in a number of microvessels. Demand, because of microthrombosis, increased demand in these factors, and then lack of resources. The third stage, generalized fibrinolysis, firstly appeared as compensatory, then having features of pathological fibrinolysis, and the fourth stage of residual effects. Here is presented another picture explaining stages. DIC, hypercoagulation stage, increased consumption of clotting factors and platelet, consuming hypercoagulable stage, considerable formation of plasma and FTP, leading to secondary fibrinolytic stage. Clinical presentation, hypercoagulation stage because of increased blood coagulability, bleeding because of hypercoagulable stage, consuming hypercoagulable stage, and bleeding mildly as a secondary fibrinolytic stage as a presentation of pathological fibrinolysis. Lab testing, For hypercoagulation stage, shortened clotting and recalcification time, increased adherence of platelet, APTT increased, AHT, fibrinogen are increased. Prolonged consuming hypercoagulable stage, the stage second. Prolonged clotting and recalcification time, reduction of platelet count and fibrinogen markedly, signs of hypercoagulation. And for secondary fibrinolytic stage, shortened clot lysis time, prolonged thromboplastin time, protamine, sulfate test, paracoagulation test, and increased fibrin degradation product. These are just signs of disseminated intravascular coagulation. We distinguish acute and subacute form of disseminated intravascular coagulation. Acute is characterized with excessive multi-organic insufficiency and appearance of hypercoagulation. Bleeding, not only this bleeding may appear just after any puncture, any injection. Smallest ruptured vessels follow to bleeding, and even without ruptured vessel wall, packed epididymis, patient will present bleeding from different parts of the organism. In contrast, subacute DIC reflex, a compensated state that develops when blood is continuously or intermittently exposed to small amount of thromboplastin. Compensatory mechanism and the liver and bone marrow are not overwhelmed, and they may be little obvious clinical laboratory indications of the presence of DIC. But clinically we can see the same hypercoagulation, microthrombosis. Duke test will be excessively short, while other tests presenting us hypercoagulation. Types of DIC presented: acute a few hours, subacute within days to weeks, and chronic. But I repeat again, nowadays there is opinion in the world that chronic is not, propose not to use term chronic. So, according to the reasons: acute because of severe infection or trauma, amniotic fluid embolism, these reasons are leading usually to development of acute, subacute, routine fetal death, and chronic in case of preeclampsia, eclampsia syndrome. Acute usually lead to shock bleeding as fast as possible, subacute microthrombin formation and bleeding, and subacute showing us organ insufficiency, chronic, mild or concealed with chronic insufficiency. And here is presented scoring system. The International Association for Thrombosis and Hemostasis present this scoring system. I hope to read it, learn and use in your practice. It will help us to make diagnosis as fast as possible. What about complications of disseminated intravascular coagulation or subsequences? Acute kidney injury, and at the same time it is clinical presentation. Change in mental status, respiratory dysfunction, hepatic dysfunction, life-threatening thrombosis, cardiac tamponade, and so on and so on. Shock and death. Complications or clinical symptoms. Management. The cornerstone of the management of DIC is treatment of the underlying condition. The cornerstone of the management of DIC is prevention of development of intravascular coagulation while we are managing pregnancy and labor. Transfusion of platelet or plasma components in patients with disseminated intravascular coagulation should not primarily be based on laboratory results and should in general be received for patients who present with bleeding. In patients with DIC and bleeding or at high risk of bleeding and a platelet count less than 50,000, transfusion of platelets should be considered. In bleeding patients with DIC and prolonged prothrombin time, and activated partially thromboplastin time, administration of fresh frozen plasma may be useful 2 to 3 doses. It should not be studied only in laboratory tests alone, but should be considered in those with active bleeding and in those requiring an invasive procedure. What does it mean? If you have patient with excessive active bleeding, you may even don't wait the results of lab tests, start to give her 2 to 3 doses one after another of frozen plasma. Severe hyperfibrinogenemia less than 1 gram per liter that persists despite VVP replacement may be treated with fibrinogen concentrate or cryoprecipitate. In cases of DIC where thrombosis predominates, therapeutic doses of heparin should be considered. As about heparin, theoretically and practically, when patient presenting hypercoagulation, it is just indicated. But when there is appearance of hypercoagulation or consumption coagulopathy, which is happening because of, as a result of hypercoagulation, not so easy psychologically to make heparin. Thus, usually it is done only in situation when we have laboratory and laboratorian diagnosis proving us development of this situation. Thus, in this case, we may try to make heparin microdoses. Usually it is done subdermally in the area around the navel. But in any other cases, it is not so widely useful, only if you have provement with lab tests that it is just indicated to make heparin therapy. Here is presented clinical feature of petechial bleeding in patient with disseminated intravascular coagulation. If you was thought to make some surgical intervention to this patient, she will present uncontrolled hypercoagulation bleeding as a manifestation of disseminated intravascular coagulation. But just now she has bleeding, become capillary bleeding per depidism or bleeding at the site of injections. And the last one, if we will have time to discuss it, it is hemorrhage shock. The hemorrhage shock is condition produced by rapid and significant loss of intravascular volume, which may lead subsequently to hemodynamic instability, decreases in oxygen delivery, decreased tissue perfusion, cellular hypoxia, organ damage, and death. Immediate perfusion of organs results in inadequate perfusion of organ, which is main component of hemorrhage shock, any shock. Inadequate perfusion of organ results in insufficient availability of oxygen to satisfy the metabolic needs of the tissue. Catabolic state develops. The consequences of these changes are inflammation, endothelial dysfunction, disruption of normal metabolic process in vital organs. Even the only endothelial dysfunction means generalized dysfunction of the organism. Catabolic state develops means the same. So we had to understand that hemorrhage shock is one of the most important situations, not only in obstetrical practice, but any branches of medicine. Once these events become established, the process of shock is often irreversible, even if volume of red cells are correct, even if the volume of circulating plasma, and replacement of lost red cells is already done correct. It is rather difficult to make resuscitation of patient when this catabolic status is already developed. The principal goals of management are controlling of the source of the blood loss, restoring adequate oxygen carrying capacity, maintaining adequate tissue perfusion. Patients with severe postpartum hemorrhage are at risk of development of hypothermia and some other complications that contribute substantially to morbidity and mortality. It must be prevented to greater promptitude. Hemorrhagic shock can be rapidly fatal. Successful treatment of massive postpartum hemorrhage depends on effective collaboration among all members of the patient care team. So, few words about estimating of blood loss. Here are presented types how we will make to estimation. Nelson formula, Lieber's method. You may download it, save it to yourself and use it in your practice. Shock index. Everybody had to know what is shock index or Algover index. Heart rate divided by systolic blood pressure has been suggested as such a marker that can be used to predict the severity of hypovolemic shock. Shock index means pulse rate divided to systolic blood pressure. Here is presenting this table presenting shock index in relation to different types of blood loss. Modified shock index. Modified shock index means ratio of heart rate to mean blood pressure. And here is presented the formula. How to estimate blood loss according to the blood density hematocrit, classes of hemorrhage shock. I hope you already told about it during the second course of studying in our university. Classification by class 1, 2, 3, 4. Blood loss, class 1, not more than 50% of blood loss, percent of circulating blood. Clinical pictures are presented here. Phase of compensation, phase of decompensation, phase of cellular damage and danger or death are phases of hemorrhage shock. First, second and third phases of hemorrhage shock, and management of hemorrhage shock agent interference is indicated as follows. Detect the cause and arrest hemorrhage, establish an airway and give oxygen by mask or other tracheal tube, elevate the legs to encourage return of blood from the limbs to the central circulation. 2 or more intravenous routes are established for blood, fluid and drugs infusion. Restoration of blood volume by whole blood cross-matched from the same group, crystalloid solution, colloid solution. And drug therapy is presented here. Analgesics, corticosteroids, sodium bicarbonate, vasopressors, dopamine, beta-adrenergic stimulants, monitoring, central venous pressure, pulse rate, blood pressure, urine output, pulmonary capillary pressure, clinical improvement in the pallor, cyanosis, ear hunger, sweating, and consciousness. Management of hemorrhage shock is intensive therapy, resuscitation of the patient who may have death. So we tried to represent you the most important points in relation to bleeding, which we may meet in our practice, and the third stage of labor, postpartum period. Thus, we hope it will help you to get education, to get more education. Everybody had to use this lecture. I propose to use this lecture as direction for further study, direction for further finding of special information. Thank you for your attention, my dear colleagues. Hope it will help you.